adhere to. My name is Dr. Amen Omorige, Registrar, Federal Medical Center, Asaba. The ground rules as follows. All should endeavor to rename their devices, and then you mute your device before the lecture will start. I will last for 30 minutes. While the lecture is in progress, if you have any question, you can type it in the chat box. An answer will be provided at the end of the lecture. While answers have been provided, if any of our trainer has any comments, he or she should kindly endeavor to signify by raising up his or electronic hand, and then audience will be given. At the end, the president will round off and will call it a close. So at this junction, I want to hand over to the presenter, Dr. Igwehi Okotuku, a senior registrar at the University of Benin Teaching Hospital, Benin City. The floor is open to you. You can continue. Hello, presenter. Please, the floor is, can take the floor, please. Presenter. Please, can you hear me? Hello?
Yes, louder.
We can hear you. We can hear you, ma'am.
Okay, Dr. Kosofu, you can start your presentation.
Can the speaker, can the presenter unmute, please, so that we can hear? Please unmute and start the presentation. Presenter, you're still muted. Please unmute.
Yes, it's disturbing. Now, I'm not going to
Presenter, we are not hearing you. Please start from the first slide and unmute. You are muted. Nobody is hearing you.
Can you hear me now, please?
Yes, we can hear you now.
Hello? Oh, okay. Good evening, everyone. So sorry for the hiccup.
Good evening.
My name is Igwe, the Pegwe of Otofun, a senior registrar in Biology UBTH. And this evening I'll be presenting the topic, an aesthetic management of tracheosophageal fistula. By way of introduction, tracheosophageal fistula is a congenital anomaly with an abnormal connection between the esophagus and the trachea. And it requires urgent surgery and careful anesthetic management because of the peculiarity of the case, because the patients have high aspiration risk and ventilatory challenges. The global incidence is about 1 in 2,500 to 4,500 births. Nigerian data is limited, although some studies say 1 in 3 to 4,000 births, with more incidence in males than females, with males having 60% preponderance and females having 40% preponderance. While TOF may occur in isolation, up to 50% of individuals have of infants with tracheosophageal fistula, they have it, and the most common being congenital heart disease. So if you see a child with tracheosophageal, screening for congenital heart defects, and the most common type is the type C, as we'll see. In addition, up to 20% of TOF infants are diagnosed with VACTER, which is rectal malformations, cardiac defects, the renal agenesis, and limb abnormalities, and maybe radial dysplasia. So this is the percentage of the frequency of associated VACTER effects and tracheosophageal fistula. So 23% of patients with tracheosophageal fistula have vertebral anomalies, while 3% of those with 10% of those with tracheosophageal fistula you find who have tracheosophageal fistula have cardiac defect, and 10% of them have rectal malformations. The etiology of tracheosophageal fistula can either be congenital, which is present at birth, or it can be acquired. Congenital tracheosophageal fistula often occurs most times with esophageal atresia. Like I said before, the most common type is type C, and that one is associated with esophageal atresia, and is thought to result from a failure of the proper separation of the trachea and esophagus during fetal development. Acquired tracheosophageal fistulas can result from iatrogenic causes, for example, prolonged intubation, trauma, lung cancer, infections. Congenital tracheosophageal fistula is as a result of developmental defect, because the trachea and the esophagus, they develop from the same primitive foregut. And about 4 to 8 weeks of gestation, a wall forms to separate them. So if there's anything that prevents the formation of this wall, that child is going to come down with tracheosophageal fistula. And there are some genetic factors that may play a role in the development of tracheosophageal fistulas, like there might be genetic mutations, like the sonic hedgehog gene. That gene has been linked to VACTER, and those people with mutations in that gene can have tracheosophageal fistulas. Other associated symptoms of syndromes you can have in trisomies 13, 18, and 21. You can have tracheosophageal fistula in people who have CHAD syndrome, which is a syndrome that has multiple congenital anomalies. And then some maternal medications have been implicated in the development of tracheoesophageal fistulas, such as imidazoline, and is a decongestant, a nasal decongestant, and it's been implicated in the development of having an increased risk in or a role to play in development of tracheoesophageal fistula. Other risk factors are first pregnancy, increasing maternal age, because with increasing maternal age, there are a lot of chromosomal abnormalities and gene abnormalities associated with increasing maternal age. Then the rate of multiple births, because of the multiple hormones and factors associated with multiple pregnancies, a lot of cell division and all that, so there may be missense or skipping of some gene sequences that may result in tracheoesophageal fistula. And then IVF patients, obviously, most times are patients who carry out IVF usually give birth most times to multiple pregnancies, and these factors come to play. The acquired tracheoesophageal fistula you can get from iatrogenic injury, like surgery, can occur as a complication of surgical procedures involving the trachea, in the esophagus or trachea, maybe like laryngeal tumor excision or intubation. Blunt trauma to the chest or neck can also cause tracheoesophageal fistula. Lung cancer, especially in the context of chemotherapy, when you give chemotherapy agent like bevacizumab from chemotherapy radiations, these patients can come down with tracheoesophageal fistulas. Infections such as tuberculosis can lead to TEF. Prolonged mechanical ventilation because of excessive cough pressure from endotracheal or tracheostomy tubes. And most times, if a patient is going to be on the tracheostomy tube for long periods, you opt for elective tracheostomy, even though tracheostomy in itself can also cause a tracheoesophageal fistula. Because of trauma can cause tracheoesophageal. The normal normal anatomy and then the anatomy of tracheoesophageal fistula, you can see a connection between the trachea and the esophagus here. Okay, so this is the a figure depicting the development of the esophagus. So from the foregut, you can see the respiratory diverticulum is the blue one, and the guts is the orange, the yellow one. And within the 4th to 6th week of life, there is a wall that comes and separates them. So any defect along this wall will cause a tracheoesophageal fistula. So there are 6 anatomical variations of TOF. How we normally put it is okay, the type C is the most common. So like in type A, you can see that there is no fistula, there is just atresia. And then in type F, you can see that there is atresia, no fistula. The first one has a blind pouch. So how you can easily know it is B, C, D, E, you say proximal, distal, together, and H. So the most common one is the C, which is the distal, proximal. There's a blind pouch in the proximal part, and then the distal part has the fistula connected to the gut. So in type A, like I was saying, in type A, there is no tracheoesophageal fistula. There is isolated esophageal atresia, and it's the second most common. So in this place, the esophagus ends in a blind pouch. There is no connection between the esophagus and the stomach, the upper esophagus and the lower esophagus. There's no connection between them. In type B, there is an esophageal atresia with proximal fistula. In type C, there is a distal tracheosophageal fistula and an esophageal blind pouch. This is the most common. So 90% of the time you see a patient that has tracheosophageal fistula, this is the form they usually present with. Type D, there is a proximal and distal tracheosophageal fistula, and type E, the esophagus is continuous, is not interrupted, and most times it's often diagnosed later in life due to recurrent pneumonia, because there is no blind pouch and some gut contents from the mouth can get to the stomach. It's not easily picked up in this group of patients. So it's usually diagnosed later in life because the recurrent aspiration from the gut, or the contents, the gut content seeping into the trachea will cause recurrent pneumonia. And in the course of investigation, these patients will be found to have tracheoesophageal fistula. So because of the tracheoesophageal fistula, the patients have a risk. There's risk or a very high risk of aspiration and pneumonitis. So the diagnosis of tracheoesophageal fistula as a congenital ailment is not easily diagnosed prenatally. Most times, the most common prenatal ultrasound finding is polyhydramnios, and anything that would prevent swallowing of amniotic fluid by the fetus would cause polyhydramnios, and there are lots of conditions that would prevent the fetus from swallowing amniotic fluid. So when the fetus cannot, it's not a specific sign. It's a very non-specific sign, and there, because of this, most of the tracheoesophageal fistula cases are diagnosed postnatally, even in very high resource settings, because even if you go for both the investigation, most parents or most pregnant women go for most times the ultrasound scan because of the risk of ionizing radiation to the fetus. So they're only exposed to normal ultrasound scan and an anomaly scan at around 20 weeks. So postnatal presentation, how this patient presents, the child is a newborn. And then if the child is not born in a tertiary hospital setting where as a result of high awareness of tracheoesophageal fistula, most times children born in tertiary hospital settings, as the child is being born, an NG tube is passed immediately to see if it goes down. If it doesn't go down, then the child is flagged as having possible tracheoesophageal fistula, and the child is investigated further. So postnatally, what you find is they give birth to the baby, and then there's excessive salivation. The child chokes with feeds, and then the diagnosis of esophageal fistula is made when you pass a catheter. Most time in settings here is a nasogastric tube. You pass a catheter, and the catheter refuses to advance more than 10 cm into the esophagus. So anytime you have a catheter in a newborn, that does not advance more than 10 cm into the esophagus is suggestive of esophageal atresia. And the confirmation is done with a chest radiograph. Then
Please, your screen is not visible anymore. We can't see your slides anymore.
I think it's network. Let's hope she'll. Please, Dr.
Oh. I was a unit. Tracheosophageal fistula. I'm okay.
I'm sure she'll be back soon. But is she using her phone?
Can you hear me now, please?
Yes.
Oh, sorry, I had network just hear me out. Most times the patients will present with choking on feeds, excessive salivation, and confirmation is done with a chest radiograph showing a catheter coiled in a blind esophageal pouch. So this is a picture of a chest X-ray. You can see the catheter, the blind pouch. You can see the esophagus ending in the blind pouch just around the aorta. In this chest radiograph. Then this is an abdominal X-ray. You can see loops you have the esophagus ending in a blind pouch close to the vertebral, close to the spine. You can see the esophagus ending in a blind pouch. So this is confirmation of tracheosophageal fistula. In low resource settings, patients are typically referred from peripheral centers to tertiary health facilities for definitive treatment. And the referral process can take several days. Sometimes these patients have already gone home and thereafter rushed back to the hospital 2 or 3 days later. So the later the patient presents, the more complications the patient has. So complications such as aspiration, pneumonia, even overt sepsis can bring the patient back to the hospital. So as arrival at the tertiary facility, if the condition is poor, the operative repair is delayed for 3 days to 2 weeks after birth. It's an urgency, not an emergency. So first of all, you need to correct all the metabolic derangements. You need to place the child on antibiotics, make sure the child is stable, make sure the child is rehydrated, because these children will come in dehydrated because no feeding. And remember that these are neonates and they have their percentage body water very high, above 80%. So during this waiting period, when you are waiting for surgery, you put an NG tube in the upper pouch and it is intermittently suctioned using a low pressure suction. So you can put it, or you put it with a continuous intermittent suction or continuous suction, but using low pressure. You want low pressure so as not to cause some barotrauma to the esophagus. You correct fluid and electrolyte imbalance, and then you manage sepsis with appropriate antibiotics. Then for complex cases or unstable patients, temporary procedures may be necessary before a definitive repair. So instead of having putting an NG tube indefinitely, so the child can have the repair staged. You can have first is a cervical esophagostomy. So at least you can drain the upper pouch, because the esophagus ends in a blind pouch and the salivary glands keep secreting saliva. The patient reflex, as in because of the reflex, keeps swallowing saliva. So the patient ends up swallowing so much saliva and regurgitating this saliva. So you can do a plan is an esophagostomy, first of all, to keep draining the upper pouch. So that will remove the need for the NG tube or the continuous suction to drain the upper pouch. Then the child needs nutrition. The child needs to be fed. So you place a gastrostomy for enteral feeding before you can now come for a definitive repair once the neonate is stabilized. So you need to drain the pouch to prevent further the cervical, the esophageal pouch, to prevent further aspiration of the saliva, and then a gastrostomy to ensure that the infant or the neonate's nutritional requirements are met. And then the preoperative management, they are prone to aspiration, as we said, and they present with respiratory complications. So in the chest radiograph, another thing you are going to look out for is pulmonary infiltrate. You look out for infiltrates, and then you have to treat the pulmonary complication to reduce morbidity and mortality. So if these patients have a pneumonia, you have to treat the pneumonia or treat the pneumonia or the pneumonia and the pneumonitis. You have to manage it and make sure it is completely resolved before the patient is taken into theater. So to minimize the risk of aspiration pneumonitis, the first thing you do, you stop all oral feeds, you maintain upright positioning, and then you keep suctioning the upper esophageal pouch to reduce the saliva accumulation, which will then pull and get aspirated, and then the child keeps coughing and keeps choking. Then something you do a bronchoscopy. And why would the bronchoscopy is done? The bronchoscopy is done in places where there's the bronchoscopy is available. You do a bronchoscopy up to know or to determine the location of the fistula, the characteristics of the fistula, the size of the fistula, so that you can use to plan your anesthetic management. So the bronchoscopy will determine whether the area or the size, the location, the characteristics of the fistula, and it also determine the presence of tracheobronchitis. So tracheobronchitis is when the trachea and the bronchi everywhere, it's all inflamed. And in this state, when the patient has tracheobronchitis, you can't do surgery because you have to provide general anesthesia, and you can't provide general anesthesia to this group of patients. So the bronchoscopy will determine or influence the anesthetic management usually. So pre-repair, the bronchoscopy, so you can see the picture of the trachea, you can see the tracheal rings, and in there you can see at the distal part, the fistula there, connecting the trachea and the linking the trachea and the esophagus. So you can see the fistula there. So this bronchoscopy, usually what does it do? It may change the operative management, especially if you think it's a high one, and it ends up being around the carina of the lung. So you will change the operative management in this patient. It will determine the fistula location, like I said before, the characteristics and the presence of tracheobronchitis, and you will be able to locate the aortic arch. The aortic arch, the location of the aortic arch will depend on whether the surgery, the fistula repair, is going to be done in the left lateral position and in the right, or in the right lateral position. And if it's done in the left lateral position, so it will determine the position the patient is going to take and the type of double lumen tube we are going to use for this patient. So other pre-existing perioperative assessments you have to do, you will do assess for cardiac defect. So you do an echocardiography. So the preoperative echocardiogram, you look out for VSD, ASD, or tetralogy of Fallot, and then of aortic arc anomalies. So about 5% of patients have a right-sided aortic arc requiring a left thoracotomy, while 95% of them, they will have a left-sided aortic arc. So you can do a regular right-sided thoracotomy. If VACTAL anomalies are suspected, additional diagnostic tests should be performed. Lumbar ultrasound, if there's a sacral dimple, to know if the child has myelomeningocele. Then it's also important so that to plan for further anesthesia for post-op analgesia for this patient. And then you do a renal ultrasound to rule out hydronephrosis or renal agenesis, which may be present in this patient, and it may affect the anesthetic management. So the intraoperative management, you have to plan. This is not the patient you just wake up and take to theater. It's a multidisciplinary approach. You have to plan. The pediatric cardiologist has to be involved, pediatric surgeon, pediatric respiratologist, and then the neonatologist, because this patient is going to be spending time in the neonatal intensive care unit post-op. So it is multidisciplinary approach. So you plan for your surgical technique, the airway management, and then the potential for blood loss. In neonates, when we for blood, you transfuse them blood for blood, so you have to match blood loss. So you have to plan for all this. And then there are two main approaches for TOF repair. The first is open thoracotomy, which is the traditional one, which most of us in Nigeria still do because of the resources available to us. But the gold standard right now is thoracoscopy. And thoracoscopy is minimally invasive, it requires specialized training, and it's performed using fiber optic cameras. The advantages of thoracoscopy is, first of all, it reduces musculoskeletal complications, like such as wind scapula, because when you do, there's an incision on the thoracic wall, on the lateral thoracic wall, they might transect long thoracic nerve, and then the patient will come down with wind scapula. There is less, you don't have to deflate a lung to get to the trachea and the esophagus, so there is less desaturation, and then there is reduced there is no desaturation, there is no reduced venous return due to IVC compression when you do the open surgery. And then the only issues you have is you don't have, and then you don't also have so much hypercarbia and acidosis, which is poorly tolerated in neonates. When neonates are exposed to hypercarbia and acidosis, they have it predisposes them to having cardiac arrest, so you don't have these problems. But with open thoracotomy, we prefer this in developing countries because of limited access to thoracoscopy. The positioning for open thoracotomy is usually left lateral decubitus for right thoracotomy, and left thoracotomy if the right-sided aortic arch is present. Like I said before, the right-sided aortic arch is present in about 5% of cases. So you can do this repair in one stage, or you stage it. You stage the procedure. In one stage repair, you can do fistula ligation, anastomosis of the esophagus. So if the fistula is near the carina, you need a one lung ventilation, and this one lung ventilation predisposes this neonate to hypoxemia, hypercarbia, increased pulmonary vascular resistance, and atelectasis. And in these cases, you have to be careful to re-expand the lung to prevent atelectasis post-op, and then post-op hypoxemia, and post-op hypoxemia. So cross-match blood should be available, and then if there is parenteral nutrition should be made available, because right after, these patients won't be able to feed. So if you're doing a one-stage repair, make plans for TPN for this patient, and then central venous access should be secured, peripheral central venous access and arterial length should also be secured in this patient. The anesthetic management, induction most times with sevoflurane, because these patients, you want to avoid positive pressure ventilation. So you don't want to bag this patient, don't want to manually ventilate this patient. So most times, if you want to stage the repair, the gastrostomy, the feeding gastrostomy is usually done first with the patient with bag, and then the patient breathing spontaneously with sevoflurane. You do the feeding gastrostomy before you go ahead with your intubation and then the repair of the fistula. So you have to monitor this patient, strict monitoring, use your ECG, BP pulse, end-tidal CO2, temperature probe. Temperature very important because these are neonates and you need a thermoneutral environment for this patient. So you need pulse oximetry, one probe. But if the child has a PDA, or it has a doctor-dependent cardiac lesion, pre and post-doctor, so you have to have two SpO2 probes, one on the left and one on the right. Then you need continuous arterial line for ABG, continuous hemodynamic monitoring, ABG, usually placed in the left upper extremities, and then at least two peripheral IV lines, one for fluids and one to rush or to give your blood and your blood products. So airway management and induction. So you intubate while minimizing gastric distension. So how to do this? You make sure the patient, the tube passed. You have to suction the tube past in the blind pouch if the patient has not had an esophagostomy done, because gastric distension can impair ventilation and cause hemodynamic collapse. So you can do an awake intubation in this patient. If you have a fiber optic bronchoscope, you can do an awake intubation. Otherwise, you can do inhalational induction and then you intubate this patient.
Hello, presenter. Please, you have 5 minutes more.
Okay.
Thank you.
Yes. So, purpose of the bronchoscopy, after you intubate the patient, you now do a bronchoscopy. First of all, if you have not done a bronchoscopy pre-op, you do a rigid bronchoscopy to know the location of the fistula, and it will assist in ETT placement. So most times when you want to intubate this patient, if you don't have a fiber optic bronchoscope, you intubate the right lung. You do a deliberate right endobronchial intubation, and you keep bringing back the ETT until you stop hearing the air leak. So if not, you have a fiber optic bronchoscope, and then the surgeon finds out the location of the fistula. So the ETT is put just distal to the fistula so that to ensure adequate ventilation for this patient. If the fistula is at the carina, which is at the carina, you have the ETT placement is challenging because there is nowhere to advance the endotracheal tube beyond the carina. So you have to place in a Fogarty catheter. It's a catheter that has like a balloon to kind of seal that the fistula up, and then it prevents gastric aspiration. So the confirmation of ETT placement, you auscultate your breath sounds, you do a chest radiograph, you have an ultrasound in theater, point of care ultrasound, you can check. Then you can do a gastrostomy bubbling test if the child already has a gastrostomy. So you put air into, like, you put the, as you bag the patient, you check if the gastrostomy is going to bubble, or if there are bubbles going to come out of the gastrostomy tube. Or you place the gastrostomy tube into a fluid, into normal saline, and then you bag the patient to look out for bubbles in the gastrostomy tube. So in developed countries, the gastrostomies are not routinely performed because they have fiber optic bronchoscopes, and these the lesion or the ailment is found out on time. So though after passing your gastrostomy tube and securing your airway, you can now place the patient under deep anesthesia using muscle relaxant. And then the patient is now placed in the lateral decubitus position. You pack pressure points. And then the challenge of this particular case is because they are working in the airway, there are going to be a lot of blood and secretions in the ETT, causing airway obstruction, your tube. So you have to make sure you keep suctioning intermittently the obstruction to prevent hypoxemia in this patient. And then because of, if the patient has a low TEF, you will have to surgically retract the lung and cause maybe collapse of one lung. If you are doing one lung ventilation, to increase the patient's risk of hypoxemia. So in this case, you have to have close communication with the surgical team, ensure availability of intubation in equipment in case of accidental extubation, because they are working in the airway, shared access, accidental extubation, and extubation, and prepare for emergency reintubation. Then you have to continuously monitor ventilation, oxygenation, and your end-tidal CO2 in these patients. And then in the immediate post-operative period, if the neonates full term and they are over 1.5 kg, without comorbidities, they may be extubated post-surgery with minimal stress. So you want to extubate them deep. But some people, some school of thought are wary of extubating them deep because they feel that if you have to re-intubate this patient to the already repaired fistula, so most people prefer, if there are two schools of thought, awake intubation and then deep intubation, awake intubation or deep. And then the infants who have congenital anomalies because of their peculiarities or complex
It appears the presenter is having network challenge. You can't see the slides anymore.
Hello. So sorry, network.
Continue, we can hear you. Your time is actually up, but just try and round off.
Oh, okay.
All right, thank you.
Oh, okay. So, what are the immediate post-operative care you may need? Then, ventilation. We do challenges in low settings because most ventilators don't have settings for children or children less than 5 kg. So it has you have difficulty adapting ventilators for use in these patients. Then erratic blood gas availability and limited neonatal trained nursing staff. So in pain management for these patients, you can use caudal epidurals where available. But most centers use opioids and paracetamol, rectal paracetamol. Intercostal neck blocks are sometimes performed, can have anastomotic leaks, which are really dire because if you have an anastomotic leak, the patients are prone to mediastinitis, and it's usually a fatal complication. So because of instrumentation to the esophagus, the patients may have esophageal strictures, which we manage with 2 to 3 balloon dilatation, surveillance for up to 3 years post-op. Long-term complications, they will have gastroesophageal reflux disease. They might need nursing fundoplication because of this. They may need to anchor this the fundus of the stomach later in life. Esophageal dysmotility because of the trauma to the esophagus during the surgery. They can have obstruction and growth failure, tracheomalacia, stridor, apnea, and recurrent pneumonia. But all these things may improve by age 3 to 5. Severe cases may need tracheopexy or aortopexy. Mortality rate in developed countries is less than 10%. Diagnosis based on weight and presence of birth-weight infants with cardiac anomalies, obviously because of the peculiarities that they have. The SPIF classification, birth weight of 1,500 grams, no major cardiac anomaly, survival 98%. Birth weight less than 1,500 grams, they have major cardiac anomaly, they have survival rate of 82%, and birth weight less than 1,500 grams and major cardiac anomaly, they have survival rates of about around 50%. So it's a 50-50 chance with these infants. So in low resource settings like ours, we compared to the 98% success rate in developed times, our mortality range is from 40% to 80% in low resource setting, which is really, really high. The major cause of the mortality is late presentation with aspiration and pneumonia, limited neonatal intensive care feeding, and lack of total parenteral nutrition for early feeding. So the early postoperative complications, sepsis, respiratory failure, late anatomic strictures, GERD, and tracheomalacia. So in long-term, children with long-term follow-up and multidisciplinary support. So the challenges here in Nigeria, like we said, late diagnosis, limited neonatal ICU capacity, and shortage of trained pediatric anesthetists. So global trends now, they use thoracoscopy to repair. That's the gold standard in high resource settings. They use high frequency, air frequency oxygen jet ventilation for unstable neonates. And then they use simulation-based training for and errance protocols to train and retrain their healthcare workers. So prognosis has improved dramatically towards the end of the 20th century, approaching 100% in developed countries, about 98%. So when the esophagus is successfully separated and reattached, they have difficulty in swallowing, like we said before. So in conclusion, clinicians must recognize that children with syndromic COF, especially those with coexisting complex congenital heart disease, will need additional surgeries and will be more complex to manage in the perioperative setting. Principles of pediatric anesthesia should be adhered to in the perioperative management of these patients because it plays a vital role in the outcome of the surgery. Resuscitation of these patients is the most important phase of the perioperative management. So it requires expert anesthetic planning, early recognition, multidisciplinary care, and training. So these are my references. Thank you very much.
Thank you, Dr. Gwehi Ofotuku, for your wonderful presentation. Now we'll go to the questions. There are some questions in the chat box already. We'll go through those questions, and then if you have any further question, you can kindly raise your electronic hand. All right, Dr. Akanigba asked a question. He said, is nasogastric tube routinely passed in the newborn? Then what are the risk factors that will warrant passage of the nasogastric tube? That's the question for Dr. Akanigba. I don't know if I will have to read all the questions or you take it one after the other.
I would like to take it one after the other. Yeah, most times in my center, they don't pass the nasogastric tube. When they are suctioning the patient, as the patient is born, as they are suctioning, they just put in the nasogastric tube and to see if the patient, if the tube, if the nasogastric tube would advance beyond, just the way they pass, they do that and they put the suction also. They put it with a suction catheter, so they put it into the mouth and then they put it into the anus to check for imperforate anus in most cases. So that's what is obtainable. It's not like the nasogastric tube is passed for feeding. It is just to check, just easy to suction. In that process, they advance it and see if it goes beyond 10 cm through the nose or through the mouth, and then they take that same tube and pass it. They take another tube or that same tube and pass it through the anus to check for imperforate or anus or anorectal malformations.
Okay, thank you for the answers. Dr. Belema has 3 questions. The first one is, how do you perform awake intubation in a newborn? The second question is, what size of double lumen tube would you use? Then the last question, the third one, is where are patients managed in the post-op, that's post-term repair of tracheosophageal fistula? Please, did you get the question?
Okay, you said the first question is okay, so where
how is awake intubation done in the newborn? And then what is the size of double lumen tube you will use? And where are those patients managed in the post-op period? Hello, I can't hear anybody again. No. Hello.
Are you hearing me, please?
We can hear you now.
I can hear you now. Yes, can hear you now. But we've not heard the answers to the questions from Dr. Belema.
Oh, okay, okay. I said for the double lumen tube for neonates, I said I don't know of any double lumen tube lower than 26 French, which is what is used for children. But you can use a normal cuffed endotracheal tube, cuffed endotracheal tube, high volume, low pressure tube, or 2.5 to 3.5 internal diameter. But I don't know of any tube less than 26 French. And then the children are usually managed in the SCBU or in the NICU that has ventilatory capacity.
Okay. The third question is from Dr. Jose Maria. He said, how is anesthesia planned in patient who already has aspiration pneumonia?
Okay. The patient who already has aspiration pneumonia, the aspiration pneumonia is managed first before the patient is booked for surgery. So you do your medical management of your aspiration pneumonitis, you give your steroids, your furosemide, you give your hydrocortis, your furosemide, your hydrocortis, the dexamethasone at the rate of 0.15 milligram per kg, and then furosemide 0.5 to 1 milligram per kg at least for 48 hours, and then antibiotics to make sure that has resolved before you plan the patient for surgery, because the pneumonia puts the patient at higher risk of morbidity and mortality compared to if the patient doesn't have aspiration pneumonitis. So you first treat the aspiration pneumonia. You prevent further regurgitation and aspiration by constantly suctioning the patient with the tube, the tube inside the pouch. And then if amenable, you may be able to do a gastrostomy with face mask and spontaneous respiration in that infant, in that neonate rather.
All right, thank you very much. The last question I have here from still Dr. Akaniba, I said, what are the pre-operative risk assessment grading for tracheoesophageal fistula? So what are the pre-operative risk assessment grading for tracheoesophageal fistula?
Can you hear me?
Okay, I hear you now.
Oh, okay. Then there are different pre-operative assessment risk for tracheoesophageal fistula. There is the Spitz classification, which I talked about. Then there's the Watterson classification. The Spitz classification, birth weight greater than 1,500 grams with no anomaly has a 95.8% survival rate. Birth weight less than 1.5 with less than 1,500 grams or major cardiac anomaly has a survival rate of 82%, and birth weight less than 1,500 grams and major cardiac anomaly has 50% survival rate. The Watterson classification, any weight or weight greater than 2.5 kg, you can go for it. The Watterson classification talks about when you are going for repair. The Spitz classification talks about survival rate. So the Watterson classification, weight greater than 2.5 kg, you are advised to have an immediate operative repair. If the patient does not have features of tracheobronchitis or pneumonitis, you have an immediate operative repair. 1.8 to 2.5 kg, you have, or the patient has pneumonia or congenital anomaly, you have delayed repair so that you optimize these patients further. And less than 1.8 kg with severe pneumonia, you stage the repair, meaning you first do an esophagostomy before you do a gastrostomy, before you now come around to do the atresia, the fistula repair.
All right, thank you for the
classification system, and it just divides the people into high risk and low risk. That's off the top of my head now. Thank Thank you.
All right, thank you for your presentation. I'll open the floor to our trainers to make their contributions. Please, the floor is open to our trainers to make their contributions. Okay, I have not seen any.
Yeah, hello.
Yes,
This
good
is
evening.
Dirty.
Good evening, sir.
Yes.
Good evening,
Thank you
sir.
very much. And thank you, the speaker, for a brilliant presentation. I just want to make a comment and to underscore the importance of this topic. Those who have been, were at the exams, I think wax, anesthesia, this featured actually as one of the questions for the exam. So it is a very important topic that residents should be conversant with. And just to let you know that there is, I don't know that Professor Desali is on this call, but on our behalf, I want to say that the President, Pediatrics Anesthesia Society of Nigeria President, Professor Desalu, is anchoring a study currently on anesthetic management of tracheosophageal fistula AMTOP study. So a number of centers are involved and it is ongoing. She wanted us to document, we have to see the trend of our practice in the management of this complex pathology so that we can find a way forward. So just for you to know this, thank you very much.
Thank you very much, sir, for your contribution, sir. Please, more contributions from our trainers. Okay, in the absence of any more contribution from our trainers, I want to hand over the floor to the president, Dr. Quinette Kalu. Please, can take over from there and can round off for us. Thank you very much.
Thank you very much. This is Dr. Queen Ekalu, President-elect and Chairman Education Committee. Our president just spoke, Professor Dati, and then we should all be familiar with the executive of the Nigerian Society of Anesthetists. Let me start by thanking the presenter for a very brilliant presentation. I want to also thank the moderator for an excellent job done. I also thank the residence training coordinator, Dr. Afam. A lot of work has gone behind the scenes. Let me thank everybody for overcoming all the challenges in putting together today's presentation, because there were lots of hiccups in terms of network challenges. The presenter herself had to change 2 different laptops and ended up with a phone. That is the kind of resilience we want to see. Those are the kind of things that make us to know, okay, you are trainable, you are able to overcome challenges as they arrive, and it makes us to know that actually you're preparing to become an anesthesiologist. I appreciate you very much for overcoming all of the obstacles on the way to this presentation. Again, I want to acknowledge the fact that you answered all the questions as somebody who prepared well for the topic. For general comments, the presenter and other residents on the call, you must avoid your endotracheal tube, your suxamethonium, your double lumen tube, your this and your that, and your arterial line, and you insert this, and you do that. Try to be impersonal in your presentations. So the preferred technique of managing this airway is the use of, you state a double lumen tube, or you state the preferred monitoring gadgets for this particular condition are A, B, C, D, that kind of thing. But avoid you and your, and you do this and you do that. So having said that, once again, I want to thank everybody for being on the call. I also want to ask you to continue to keep faith with this program, very educative indeed, as you can see. In the next few weeks, we will know whether we are going to roll out another topic that is very relevant to residents, but may not necessarily be presented the way we are doing, because the NSA is trying to roll out basic life support in the community. And then we will give you more details as they become available. Please remember to pay your NSA dues so that you keep us going as a society. There's a lot that we need to do internationally and to maintain our visibility with the WFSA and in other places that other people and other groups that we collaborate with. So once again, I thank everybody for being on this call. Thank you very much, and see you again in the next webinar. God bless you.
Thank you, Ma. We appreciate it. Thank you very much.